Thank you, Daktari. When I see Daktari, I see IPC. Isn't it? Yes. And I see quality. These are the regional champions that have really advanced the implementation of infection control strategies in the region. And we learn and value the work that Tanzania has done on IPC. It's very structured and there are results. So Daktari, thank you for the good work and thank you for your leadership as well. So as the slides go up, I just want to appreciate the organizers for this opportunity to just come and talk about infection control and antimicrobial stewardship, which are very important cornerstones for the control of antimicrobial resistance. And I think one of the struggles that we had for some time as national programs built their AMR work was trying to keep AMR and IPC in the same house, isn't it? In many of our countries, you find AMR is in a different house, and you find infection control is in a separate house. But as time has moved on, I think the value of keeping both AMR and IPC in one place cannot be underestimated. And that's what I'll be talking about this morning, just trying to bring the two together, infection prevention and control, and antimicrobial resistance. I don't know which would be better for me. So yeah, and I want to pick it up from a behavior change perspective. And yesterday when Prof. Ndegela was talking, I felt we have done a lot in terms of structure. But where the rubber meets the road is where implementation actually happens. So if you move to the next slide, just a brief about ECSA. We are an intergovernmental organization, and yes, Tanzania is one of our member states. The countries in blue are the countries that belong to the ECSA health community, but that doesn't mean that our work is limited to just these countries. We work in all the other countries that are orange, have some form of work going on. The next slide just introduce the general, if you move to the next slide please, basics on IPC and stewardship. And I say this is a hand and a glove. And I thought these were important points to just highlight today because of the practical nature of infection control and stewardship. What does it mean for the nurse? What does this mean for the person who's handling last treatments, for example? It's very practical and constant. And we can't talk about quality if we don't have IPC or AMS. And for our part of the world, and as we go through this presentation, if you are working in a facility, just try to picture your hospital. Maybe it's not part of low and middle income countries. Maybe your hospital has advanced. It doesn't have challenges with WASH, for example. Healthcare delivery and hygiene usually are negatively affected by infections. And stewardship, on the other hand, is a coherent set of actions. It's a set of interventions for a purpose. To use antimicrobials, have surveillance, and you're seeing data coming out, but so what once you have the data? I have my prevalence reports for the surgical site infections, and again we're saying that it's important to know that ultimately, oh, I can use the slide mover, thank you. You see, innovations. Thank you very much. So this is good. So what we have learned over the last maybe 6-7 years from the inception of the Global Action Plan, a lot of guidance documents have come out from everywhere. And these are supposed to end up in one country. So the focal points and the technical working groups are actually supposed to go through all these different guidance documents that have been developed and customize it to a level that is at relevant for the country. And even from the national level, you also have to take them down to your facility. It could be a referral hospital or it could be a health center. Action plan. How do you establish your stewardship programs? How do you build capacity in terms of medical education so that you're trying to build in skills and competencies right from the beginning? We looked at a summary of the joint external evaluation like feedback, just looking at where our countries are in terms of preparedness. Infection control is a cornerstone when it comes to health emergencies, response and preparedness. And where you have a health emergency, or where you have a pandemic, like we had COVID, one of the things we realized was that AMR, surveillance, microbiology capacities were all thrown at the back because the focus was now on COVID. But what everybody else was doing, while lab capacities were rescheduled or reallocated, everybody had azithromycin in their pocket, just in case, because borders were closed. I needed to be prepared. So we said it is important to look at IPC and AMS in the context of health emergency preparedness and response. And I've highlighted two areas in red because in the joint external evaluation capacities, that's from the international health regulations, we have critical core capacities that are very important for infection control and antimicrobial stewardship. One of the areas is actually focuses on multi-sectoral collaboration, and because we're in Tanzania, I will use that example. You can see we scored 4 for multi-sectoral coordination. We scored another 4 when it comes to surveillance systems, and you saw what Prof. Seni prevented. 4.3 was a 1, meaning no capacity to prevent the transmission of multi-drug resistant organisms. So you see where the gap is. Yes, I can detect, but do I have the capacity? So it looked at what was inexistent at that particular level. In terms of stewardship, both in animal health and human health, we have some form of capacity, and that is at 3 for each. When it comes to infection control, the R, which actually means respond, 4.2, for many countries is a 1. And that particular 4.2 points towards a surveillance system for healthcare associated infections. Outcome related, we can do so much, but when we don't get to the bedside, when we don't prevent infections in our patients, or when we can't be able to tell what is happening once clients come in and out of your hospital, it becomes a challenge. So we looked at that, and I go back to this WHO IPC core components because they actually carry everything that we need to make our setting safe. And of course, as I go through this particular presentation, you will realize that it is leaning more towards the human health sector, and that also speaks to what Prof. Mdegela said yesterday. 1 times 0 equals? 1 times 0 equals? 0. And the JEE is actually like that, because it doesn't just monitor capacities in human health, it also looks at capacities in animal health. But this is important because it can be applied across board. When you look at trying to change the culture, or you're trying to change behavior change within any particular setting, you must be able to build a system. You must be able to teach people or educate people, and I know we've been doing that. Are we monitoring? And when I say monitoring, it's not just at the national level, but where you work, are you monitoring the interventions? Are you able to sell your work? Prof. Seni sold Tanzania very well, isn't it? And you can see a lot of progress in the country. Are you able to live it? Living it means sustaining it. And one of his slides made me sad when we realized that 75% of the funding for surveillance was actually Fleming Fund. And yet at the end of this month, the Fleming Fund is coming to a close. What does that mean? Will we be able to sustain the same result next year during the WAAW meeting? And I think this actually speaks to our countries. So that's the point of living it. And of course, looking at the things that enable all this to happen, like the guidelines. We have developed a lot of guidelines like you're going to see. Yes, we have trained people, we have surveillance, we are monitoring. I'm not sure about the auditing and the feedback session. And of course, all this being underpinned by an enabling environment. And I say, pointing back to our resource capacities, our infrastructures, our workload, staffing levels. Do we have the adequate number of nurses, for example, to do what is required? So these next few slides just speak to what countries are doing. And that will lead me to the behavior change conversations. We have IPC programs, we have developed guidelines. There's no one who doesn't have guidelines. Are we monitoring the interventions like basic hand hygiene that has a capacity to reduce up to 80% of transmission of infections within any healthcare setting? We did very well during COVID. We had a decline in diarrheal diseases. We had a decline in respiratory tract infections. But the moment the world was declared safe, I don't know what happened in Tanzania or in Uganda or Nigeria. Suddenly, all the hand washing points in the marketplace have no water and they have no soap. What happened, colleagues? We don't know, isn't it? Behavior change. Set up to the community level, and we are very happy when we launch these guidelines. And you can see for this particular country, a lot has happened, very beautiful documents, but when it comes to implementation, they still have barriers in terms of governance, they still have IPC system weaknesses in terms of declining hand hygiene compliance. You can see from 61% in 2023 to 55% in 2024, surveillance processes can be a key barrier. I move to the next set of country that has all these beautiful guidelines. How are they being implemented by one healthcare worker? Remember, at the end of the day, it's that one nurse that must translate all these documents or guidelines into action. For this other country, again, same story, and this is one of those countries that is an exemplar that has stewardship in animal health. But how are they implementing it? So you can see they also have guides, they also have done a lot of work in terms of strengthening their surveillance system, and they've been able to implement AMS in 328 health facilities. Important is a place of monitoring and support supervision to make sure that we have this at the bedside. But where does the rubber meet the road? Having guidelines and strategies is not all, but we realize you need to be able to monitor, and I'm going to try and demonstrate this using this particular hospital I'm calling Zuri, that had a guideline developed, and they just picked on one very basic intervention, which is hand hygiene. And when they monitored their hand hygiene compliance, at baseline they were at 23%, and this is actually very good. A lot of hospitals have a baseline hand hygiene compliance rate of even 5%. And you can see after they went through a root cause analysis and they were able to have the interventions in place, they moved steadily up to about maybe 55% over a period of about 5 or 6 months. And you can see gradual increment over time. The beauty about having your data at a local level is that you're able to act on it, to influence your local interventions, and you're able to monitor impact as well. So we coupled this and encouraged local participation, identifying locally homegrown solutions, because you can have a guideline at a national level with a prescribed solution, but can it be implemented within that health center in your district, within that hospital in your district? But when you use the teams within the facilities or a particular setting, you're able to have better results. So we added another one, monitoring compliance with surgical antibiotic prophylaxis, because we realized the nurses were pushing IPC on their own. And IPC is not a nurse domain. We have to keep saying this. And the people in pharmacy were in their own corner looking at prophylaxis and availability of antibiotics. So we brought in the monitoring of surgical site infections post-cesarean sections as a way of bringing the two teams together, the infection prevention and control teams and the teams that were handling the AMR surveillance and also antimicrobial stewardship. And the teams that they began to look at data together. They would look at hand hygiene data and also compliance with the surgical antibiotic prophylaxis guidelines, and you can see some of the gaps that were coming out. For example, timing on when the prophylaxis was administered, because the guidelines for surgical antibiotic prophylaxis have a recommended timeline when this antibiotic should be administered, and you can see the difference in terms of administration for the patients that were there. So they had their data and they were able to work on it and also improve on collecting and documenting data in terms of accuracy. So you can see they were able also to determine outcomes ultimately, and I think that is what makes a lot of sense and difference at the end of the day. It's not just about data, but what does that mean to that patient? What does that mean for the system? Of course, out of the patients that were enrolled into the surgical site surveillance system, you can see over time there was an increase apparently from March, April, and May. Is it because we were following in a better way, or is it because we had more cases? But anyway, what was important is that we were able to document the number of patients that developed a surgical site infection. And for this, in any healthcare setting, is so significant. You can quantify costs. How much more has that patient who developed an SSI paid for the healthcare system? How much more in terms of healthcare worker capacity did you need to be able to take care of this patient? Because definitely they were not in the hospital for a week. They were probably back into hospital for another 3 weeks. So long stay in hospital, extended costs in terms of what they needed to make them safe again. That has been developed, but we are not always compliant to this, and that is why you find maybe patients ending up with infections that are acquired within the hospital. So of course, then behavior change becomes important as a way of making sure that we are consistent in the way that we are implementing our guidelines and that we have impact ultimately, and that impact is positive. So yesterday again, Prof. Ndegela made mention of this model for behavior change. And I think as you take down every guideline, as you take down every research that has been conducted, and that data not just remaining in a publication, but actually being used to drive action and practice by the bedside, these are areas we don't think about a lot. I read a guideline and I want to implement it directly. But am I capable? Or is my team capable? Is there an opportunity, even within the environment? I want to wash my hands, but when I go to the sink, is there water? Is there soap? One of the two. I want to practice one patient per bed, but if I'm overwhelmed in a public hospital, why do I put my extra patient? So the environment, and then the motivation. And you're here because you're all child champions. Are we motivating our colleagues enough to be able to drive change? And then when you look at the other behavior change wheel, over and above just the capabilities, opportunities, and motivations, there's a place of resources. There's a place of having training and all these aspects that need to be in place, like finances, the regulation, the service provision that is there. Do we have adequate legislation that will protect me, will protect the patient, that is pushing me towards better? So I think those are some aspects that are important for us, identifying some barriers and facilitators to my effective application of the guidelines. And when I'm able to do that, then it becomes easier for me to have impact at the end of the day. So this is one of the countries, again, they've been able to publish a lot, and you can see how they've increased in terms of publications related to AMR and IPC over the last 2 years. In 2023, they only had 4 publications that came out of their AMRCC. But as of October 2025, they had 20. So sharing this work and information becomes important. So I'd like to conclude by just emphasizing again that we need to have change in terms of our behavior from the provider perspective. The strategies will be multi-pronged, and it's important to evaluate what to change and why, even as guidelines and plans and strategies come down to the implementation level.